This is a patient post-liver transplant with Bile. He was transplanted on August 25th. So I'm using Tritome from Cook and Visiglide wire from Olympus, the TGF Q19 scope from Olympus, and this is a fresh papilla. So we're gonna engage, align with the bile duct, so that goes up. So let's see if we have the correct direction here. Okay, live. Go with the wire.
Nice.
You have a little bit of resistance there. Come a little bit. So this patient came with a 12-centimeter collection. Of course, I was upset that they sent the patient to IR. We should have drained it internally. But and patient had bilious ascites too. So clearly they have a leak. So there's no point of injecting more. Huh? So
will not help us.
Yeah, do a sphincterotomy, and then we're gonna go give me a 10-9 biliary stent.
I think this the strategy is just to decompress the biliary system and to invert the pressure there.
Yes, and your thought about combining both sphincterotomy and stent versus either one of them, combination even is better. Bo?
Here I would go for the combination as well. So yeah, nice sphincterotomy. So would you cut till the end here?
No need. You know, we stop the days of full sphincterotomies are over.
Yes.
Ambo. If we have a big stone and we need the papilla wide open, we do a sphincterotomy and a sphincteroplasty. A good sphincterotomy is important with leaks because you want to change the gradient.
Yeah.
But we don't do full sphincterotomies anymore, and we stop seeing retroperitoneal perforation that way. We have to worry that a lot of these patients also, remain coagulopathic for a while. They're sick, and we know aggressive sphincterotomies are associated with bleeding as well. Plastic stent, metal stent for bile leaks. Do you have to cross the leak or no?
So for me, if I don't see where the leak is, I like to use a plastic stent that's the highest diameter and actually being very short, because that's released the pressure more effectively than a long stent. So that's my approach. We start with a plastic stent.
What would be your opinion on fully covered metal stents? Any role? I think there's no need here to use it. Even if we would see a leakage here or larger leakage, I think this will resolve with changing the gradient.
If there's a high-grade leak and you see a lot of contrast on passive injection, which is the synchrotome, then I would prefer a metal stent.
Really?
Yeah, I don't think there's data for that. I mean, don't forget that metal stents very high risk for migration, especially without a stricture. We usually reserve them for refractory leaks, which probably account maybe for 5% of leaks. But the fluoro shot, okay, picture. So so we're done here, and our protocol is we leave this for 8 to 12 weeks. We look at the output of the drain. Once the output is gone, the drain comes out. Okay. A few weeks later, we take the stent out.